We went over the low and intermediate risk. Let's spend this hour going over the high risk, as well as the oligometastatic and even a little bit of the metastatic patients. Again, I would like to keep this high yield. I've based this off of notes, lectures from our residents, as well as questions that I've seen be more frequently asked. Everything in red is going to be a little bit more on the higher yield side. So please focus on those on each slide. I wanted to thank again my colleagues, Dr. Swanson and Tang, for the framework of this slides. So before we talk about the radiation aspects of managing high risk or very high risk disease, let's go over ADT very quickly. So the hypothalamus starts ADT production by the secretion of GnRH, and this is a pulsatile secretion. So the GnRH agonists, which is Lupron, or other ones that you are less familiar with, work by blocking that pulsatile signal and kind of creating a negative feedback loop back to the hypothalamus. And that in turn suppresses the action of GnRH on the pituitary, which then secretes LH and then goes to the testes, produces testosterone, which acts in the prostate. Over here, you see the adrenal glands can also produce androgens and DHEA that work on the prostate as well. So you have the GnRH agonists that work up here. The antagonists, like relugolix or degarelix, work by inhibiting GnRH directly or immediately, so you don't have any testosterone flares. And then the non-steroidal anti-androgens, and they may ask, like, hey, bicalutamide or enzalutamide, how does it work? What's the class of medicine? So you have to know non-steroidal, you have to know how it works. So in the prostate cancer cell itself, you have DHT, which then binds to the androgen receptor, and that translates into the nucleus and works inside the nucleus. So if you can use enzalutamide or bicalutamide to block the binding, that also blocks that translocation. Inside the cell itself, you can also have production of DHT through multiple pathways. So the 5-alpha reductase inhibitors can work inside the cell to block the formation of DHT. And then the newer class of drugs called the CYP17A inhibitors, so abiraterone is the most famous one, works inside the adrenals to block the conversion of cholesterol into DHEA. So what do we need to know? Well, know the agonists, Lupron, know how the antagonists work in relation to the agonists, know the general class of non-steroidal anti-androgens. Most commonly, they'll ask bicalutamide or enzalutamide. Know how 5-alpha reductase inhibitors act and affect the PSA. So if you remember from last lecture, you want to roughly double the PSA when you see that someone's on finasteride. And then know the mechanism of action of abiraterone. So you have to, recognize, maybe not memorize, but recognize CYP17A, all right? So like I was talking about, the hypothalamus releases GnRH in a very pulsatile fashion. So if you turbocharge it, it'll negatively feedback back to the hypothalamus and the release will stop. Now, the GnRH antagonists like relugolix, you see that they'll have a very quick effect on the testosterone because you don't have that initial flare. And after the tablets are withdrawn, the recovery of testosterone is a little higher as well. So that's how they work in two different areas. So I'm just going to focus on this because I do feel that they may ask this. So a bunch of patients were randomized to either relugolix or Lupron, and they showed that in this HERO trial, relugolix achieved improved testosterone suppression to castrate levels 96.7% of the time compared to 88% of the time. And the risk of major cardiovascular events was 54% lower. And also the recovery after withdrawal of the medicine was significantly faster. So improved suppression, faster recovery without increasing any cardiovascular events, in fact, lowering the cardiovascular events. So for high-risk patients, we will recommend active surveillance if their life expectancy is less than 5 years, surgery, which we'll talk about in the next lecture, and then radiation with hormone therapy. So in the early trials, a lot of metastatic patients were treated with just hormones. And so they investigated what benefit radiation had on top of hormones. So these two key trials were SPCG7 and MRC PRO7, and they showed that they improved both prostate cancer-specific mortality as well as overall survival. So the SPCG trial randomized patients to lifelong androgen deprivation or 3 months androgen deprivation, followed by 50 gray to the pelvis, 20 gray to the prostate, followed by lifelong ADT. So they both got lifelong ADT, but this arm had radiation thrown in the middle. And these were patients with T1b to T2, Gleason grade group 2 or 3, or any T3. Their PSA had to be less than 70. So fairly high risk, but localized prostate cancer. MRC trial, again, included a very similar group and randomized to lifelong ADT or 0 to 2 months of ADT plus 45 gray to the pelvis, boost to the prostate, and lifelong ADT. So these trials were designed very similarly, and they both found that the overall survival improved with the addition of radiation, and both were statistically significant. Cancer-specific deaths were improved with the addition of radiation as well. So when you look at the benefit of ADT plus EBRT, so the first two trials looked at hormones and they added radiation to one. Now this is looking at radiation and adding hormones to one. It showed that ADT improved all endpoints, including overall survival. Pilipit's trial, the first one, also showed the same thing. And then the second one showed all endpoints except overall survival, but the hormone utilization was a lot shorter in this one. So again, hormones improve all endpoints, including overall survival, especially if you're giving them for longer terms. So the BOLA trial, these numbers can be asked. So kind of just keep in the back of your mind what the difference was. So with external beam radiation alone, progression-free survival was 18%, disease-free survival was 23%, overall survival was 40%. Adding hormones really improved progression-free survival by over 20%, disease-free survival by over 20%, and overall survival by almost 20%. So just remember 20% rough improvements across the board for the addition of hormones to radiation. So what's the optimal duration of ADT for high risk? So we know, again, that hormone therapy can add to disease-free survival and overall survival versus short-term. So this is long-term versus short-term. There are 3 trials that looked at that: RTOG 9202, EORTC 22961, again, BOLA, and the DART 0105. 36 months was not superior to 18 months, as shown by the PCS4 trial. That did not show any disease-free survival or overall survival benefit. 18 months had a benefit over 6 months, which was a TROG study that showed improved prostate cancer-specific mortality. So bottom line is that at the end of the day, we recommend 18 to 24 months of ADT for high-risk patients in conjunction with XRT. All right, so let's just review again. So long-term, better than short-term. 36 months, not better than 18 months, but we know 18 months is better than 6 months. So we definitely don't want to do 6 months for the high-risk patients. We want to do at least 18 because of the equivalency showed by this PSC4 trial. So the DART 0105 trial looked at intermediate risk and high-risk patients, and they randomized them to 4 months of neoadjuvant and concurrent hormones plus 76 to 82 gray, prostate only, plus or minus pelvis. And the other arm had 4 months neoadjuvant concurrent hormone therapy with 76 to 82 gray, and then they did a lot longer, 24 months adjuvant hormone therapy. They showed that the long-term hormone therapy group had a 5-year overall survival of 95%, whereas the short-term hormone therapy group had a 5-year overall survival of 86%. So significantly different. The PCS4 trial randomized patients to 70 gray with 44 gray to the pelvis and looked at 18 months versus 36 months. And they found that there was a significance in the biochemical failures. The overall survival was not significantly different, and the disease-specific survival was not specifically different. So even though there's a biochemical failure difference, it did not translate into overall survival or disease-specific survival difference between the two groups. So that's 18 months versus 36 months. Is there a benefit to treating the pelvis? Well, this is a little controversial. One thing you need to know very quickly on the top of your head is the Roche formula. So just to remind you, it's Gleason score minus 6 times 10 plus 2/3 of PSA. So if a patient had a Gleason 8, PSA 24, you would add, 8 minus 6 is 2 times 10 is 20. And then 2/3 of 24 is 16. So the rough risk of pelvic nodes is 36%. So this was used to calculate which patients should join the RTOG 9413 trial, as well as the POP-RT trials. So the RTOG 9413 randomized patients to 50.4 gray pelvis and prostate only, and then also looked at the different hormone regimens for the two. Initially, they said that the whole pelvis radiation therapy had a 4-year progression-free survival of 54% versus 47%. That was significant, but an updated analysis was not significant. POP-RT looked at a similar patient group, but they had much better staging because this is a more recent trial of it out of India, and they looked at MRI pelvis and PET-CT for staging. They looked at patients who were essentially high risk and randomized them to 68 and 25 to the prostate. Remember this dose fraction, 68 and 25, it's a little unusual, versus 68 and 25 to the prostate, 50 and 25 to the pelvis, including the common iliac and external iliacs. And then they found that the failure rates were significantly higher in those who did not get treated to the pelvis. Disease-free survival was higher in those who did get treated to the pelvis. Distant metastasis-free survival was also improved with pelvic nodal treatment, but the overall survival did not change. So everything was improved except for the overall survival. And again, remember the unique fractionation on this POP-RT trial. Toxicity was roughly the same for GI and slightly worse for GU in the whole pelvic field arm. All right. So conclusions in terms of standard of care. So radiation does offer a survival advantage over lifelong hormones. That's been demonstrated. Optimal duration of hormones is still unclear, but 18 to 24 months is acceptable. Elective radiation to the pelvis is still controversial. Trials that established the benefit of radiation therapy for high-risk disease did have included within their design elective nodal radiation. However, the trials testing pelvic radiation suffered from inclusion of low-risk patients and smaller lymph node fields. So these were the Get2Go1 and RTOG 9413. So still controversial. If you're going to use it for treating your high-risk patients on the oral boards, again, just be able to justify it. Use the trials that support your decision-making and also know the shortcomings of those trials, the fractionation of those trials, as well as the outcomes. So looking at RT intensification strategies, the radiation boost is one strategy. Androgen depletion intensification is another strategy. And finally, chemotherapy is the third. So radiation boost. So looking at brachytherapy, you can boost the dose to the prostate using either HDR or LDR. There is a dosimetric advantage of EBRT. That's a much more rapid fall off. And you can also have a higher BED to the prostate with that. The one trial that you need to know that looked at the utilization of a brachytherapy boost was the ASCEND-RT trial. So they looked at 31% intermediate risk patients, 69% high risk patients, and randomized them to pelvic radiation. The first arm got a standard 78 gray external beam boost with 1 year of hormones. The second arm received 46 gray to the pelvis with a brachytherapy boost of iodine 125 to 115 gray and 1 year of hormones as well. They found that the 5-year biochemical progression-free survival was significantly higher in the LDR boost group. Metastasis-free survival was also higher in the LDR boost group, and the overall survival was similar. So again, better progression-free survival based on the PSA, better metastases-free survival, but the 5-year overall survival was similar. Now, maybe that will change as we get 10 and 15-year follow-up, because we know that metastases-free survival often leads overall survival. So this was the outcomes held for both the intermediate risks as well as the high risks. And they found that the erectile function at 5 years was similar in both groups. GI function was also similar. GU function, however, was worse in the brachy group, as you would expect. So catheterization rate was higher, pad utilization was higher, and the grade 3 GU morbidity was also higher. Most of these were temporary and reverted back to normal. But in the short term, it is something we have to counsel our patients on. There was also a retrospective review of 12 centers that looked at the differences in radical prostatectomy, external beam radiation therapy, or EBRT with brachy boost. And these were patients with a much higher risk, so 9 and 10s. So what they found was that EBRT plus brachytherapy and androgen was associated with a significantly lower prostate cancer-specific mortality compared to either radical prostatectomy or EBRT alone, and significantly better distant metastasis-free survival compared to RP or EBRT. So when you looked at prostate cancer-specific survival, it was improved. Distant metastatic free survival was improved, and overall survival overall was not improved. But again, the metastasis-free survival was seen, so maybe that'll translate into a benefit later on. So I don't know how high yield this is, but just a quick review of the acceptable brachytherapy boost doses. If you're going to boost with iodine, the dose is 110 to 115. Palladium boost is lower, 90 to 100. Cesium, they rarely ask. HDR, we're seeing a more frequent use of boosts at certain centers, 15 gray times 1 or 10.75 times 2. And now we're also seeing more EBRT plus SBRT boosts, 19 gray times 2. I would caution you to avoid saying SBRT. LDR has much more data to it. So if you're going to use a boost on top of the EBRT, kind of go the low-dose brachy route. The FLAME trial looked at microboosts. So could you take certain areas of the prostate and take them to higher doses? So they looked at mostly high-risk patients and randomized them to 77 gray and 35 fractions, 65% received hormones. And then these were compared to 77 gray and 35 fractions with a micro boost to 95 gray. Also, the same amount received hormones in this arm as well. And they showed again, so disease-free survival was improved with the micro boost, both from a biochemical perspective as a clinical perspective. Metastasis-free survival, there wasn't much of a difference. So again, remember that the micro boost helped disease-free survival, but not metastasis-free survival. There were no difference in late toxicity with the micro boost. One patient did experience a grade 4 urinary toxicity requirement permanent catheter. So it's not without toxicity. Looking at intensifying androgen depletion. So we look at the STAMPEDE arms. One of the STAMPEDE trials did look at this question, and the arm G analyzed a large group of men. Now, the Stampede trial is quite interesting, the way they designed it, but again, it's beyond the scope of this lecture. But in this group, they randomized patients to standard of care ADT versus ADT plus abiraterone. So remember abiraterone, what that mechanism of action was? They will ask it, especially in the context of this trial. 2 years of abiraterone plus prednisolone to standard of care significantly improved overall survival compared to standard of care alone. 3-year overall survival rate was 83% versus 76%, so an absolute improvement of 7%. Now, when in doubt, when they ask for overall survival improvement and you don't remember it, remember that most of these trials were powered to show a 5% difference in overall survival. So a lot of the improvements that you'll see are roughly 5%. So pick the choice closest to 5% if you absolutely don't remember what the improvement was. AAP also significantly improved failure-free survival here and wasn't without toxicity. So the more common toxicity is abiraterone or hypertension, hypokalemia, and less commonly liver toxicity. Again, splitting it between the non-metastatic patients and the metastatic patients, the failure-free survival was much higher in those with metastatic disease. Looking at the benefits of chemotherapy. So the Get-to-12 trial looked at neoadjuvant docetaxel and added it to local therapy plus a hormone therapy compared to just local therapy alone plus hormone therapy. And they found that the relapse-free survival had a significant benefit with the addition of docetaxel, but no significant difference in prostate cancer-specific survival or overall survival. Adjuvant docetaxel given after the fact showed, again, a benefit in overall survival of P of 0.03, so it was significant. And then the disease-free survival was also beneficial to adjuvant docetaxel. And looking back, these are very high-risk patients. So Gleason 9 or 10, or 2 more risk factors. So very high risk, very high propensity for spread. Those are the patients that did see a benefit from the addition of docetaxel to androgen deprivation therapy. Stampede Arm E also randomized patients to ADT plus zoledronic acid plus docetaxel, ADT plus docetaxel, ADT to zoledronic acid, or ADT alone. And these, again, were the newly diagnosed metastases, newly diagnosed metastatic patients, node-positive patients, or high-risk patients, or previously treated surgery or RT patients who have now relapsed. So that was the target group. These are the 4 different arms that they randomized to. And so they found that the addition of docetaxel to standard of care significantly improved overall survival, failure-free survival, and progression-free survival compared to standard of care alone. So adverse events were more common in the docetaxel-containing groups, with 28% of patients experiencing grade 3 to 5 toxicity compared to 9% in the standard of care group alone. SPCG13 took a slightly less higher risk population and randomized them to adjuvant docetaxel as well. And they found that the survival benefit wasn't as strong. So to reviewing RT intensification strategies. So the ASCEND trial looked at the addition of a brachytherapy boost on top of regular radiation and hormones, 1 year of hormones. They looked at intermediate high-risk patients, right? And they showed that there was a biochemical progression-free survival benefit. FLAME looked at micro boosts, that there was a biochemical relapse-free survival, but not overall survival. STAMPEDE looked at intensifying hormone therapy. And then the last 3 trials looked at intensifying with docetaxel. So what can we conclude from all that? Well, there's 3 intensification strategies that have shown improvement in relapse-free survival or biochemical progression-free survival. Overall survival is still pending on a lot of them. And these strategies may benefit the appropriately selected patients with a longer life expectancy with high-risk non-metastatic disease. So brachytherapy boost can be given for lymph node negative, SV negative, or high-grade local disease based on Ascend RT or the Kishin retrospective analysis. Microboosts are emerging as a potential treatment paradigm. Excuse me. But we haven't really started using them in mass in this country. Hormone intensification for lymph node positive, seminal vesicle positive, high PSA, or patients who were started on ADT that was suboptimal can be utilized. Induction docetaxel or adjuvant docetaxel can be used for patients with bulky disease, maybe T4 or very high risk. Everyone else should just get the standard external beam radiation with 18 to 24 months of hormones. So that's kind of a summary slide on the role of intensification. What about oligometastatic? So this is another commonly asked concept on the boards. So one area we need to look at is in the setting of metastatic disease, is there any benefit to radiating the primary? Or in the setting of metastatic disease that's limited, should we radiate everything? So we're treating the prostate alone. The pre-specified subset analysis from one large trial showed improved overall survival for patients with low bulk prostate cancer. There's support from additional subgroup analysis of another smaller trial, and treating oligometastatic disease with definitive intent has demonstrated some positive early signals, but we need more follow-up and more trials. So HORAD looked at de novo metastatic patients with who are younger than 80, but also with PSAs greater than 20, randomized them to 70 gray and 35 fractions or a hypofractionated regimen to the prostate primary and lifelong ADT versus just lifelong ADT alone. And they found that there's no significant difference in overall survival between the two treatment arms. The median overall survival was 45 months in the ADT plus radiotherapy arm and 43 months in the ADT alone arm. But when they drilled down on the subgroup analysis, it suggested that patients with a lower metastatic burden, so those with less than 5 bone mets, may have derived a survival benefit from the addition of prostate radiotherapy, but this was not statistically significant. So let's keep that lower metastatic burden and that number in mind. So again, HORAD showed PSA progression in the lower metastatic group, but no overall survival difference. Looking at STAMPEDE, so Arm H looked at de novo metastatic prostate cancer, and they randomized to 55 gray and 20 fractions or 36 gray and 6 fractions weekly to plus lifelong ADT compared to just lifelong ADT alone. And then they also noticed benefits in the lower metastatic burden. So this point is key. There is this charted group definition of high metastatic burden. So they classify that as 4 or more bone mets with 1 or more outside the axial skeleton or visceral metastases. So that's the charted definition of high metastatic burden. If you have less than that, you're low metastatic burden. So the STAMPEDE arm showed that failure-free survival was improved in all the groups, those with low metastatic burden as well as those with high metastatic burden. But the overall survival was improved only in the low metastatic burden group. So let's go over this again. This is very commonly asked. Failure-free survival improved for everybody, but overall survival improved only for the low metastatic burden group. So that's people with patients who do not meet this charted definition for high metastatic burden. So they concluded that prostate radiation should be standard treatment for patients with low metastatic burden. The STOMP trial looked at men who were staged with either choline PETs or MRI of the prostate, and looked at 62 men with recurrent disease and randomized them to either surveillance or site-directed therapy. And they find that those with site-directed therapy treatment had greater hormone-free survival and greater biochemical relapse-free survival as well. The Oriole trial looked at 54 patients with recurrent disease with up to 1 to 3 metastatic lesions and they randomized them to either surveillance or site-directed therapy, and also showed that those who received site-directed therapy had better or improved progression-free survival, as well as improved biochemical progression-free survival. Now, for patients with actual widespread metastatic disease or castrate resistant who had at least one site or more of PET-positive disease, they were randomized to standard of care or lutetium, which is a radionucleotide, and that was given every 6 weeks for 4 to 6 cycles. And Pluvicto or lutetium significantly prolonged time to first skeletal event, radiographic progression-free survival, and overall survival. So again, this is in patients with castrate-resistant prostate cancer who had at least one spot on the PSMA PET. They all showed improvement in overall survival across the groups. All right. So again, I distilled this high-risk section down to very high-yield topics, and hope that these are things that you can focus on both for clinical and written boards. Any questions about any of the topics I mentioned? Because this was high yield, I finished earlier than I anticipated. All right, if there are no questions, then let's take a break.